Bismillah ar-Rahman ar-Rahim. We are going to start now the third session on genitourinary cancers. في البداية بحب أشكر الدكتور هشام الغزالي for giving me the opportunity to share in this meeting and this session. And our first speaker will now Dr. Rasha Salah. She will talk about MRI imaging of prostate cancer.
Good afternoon, dear professors and colleagues. It's my pleasure to be here with you today. Many thanks for the organizing committee, especially Dr. Hisham Al-Ghazali and Dr. Usama Hetta for inviting me. Today we are going to discuss multiparametric MRI of the prostate, detection and assessment of aggressiveness. First, I'd like to express my gratitude to Mr. Radiology Center, where I performed all the work there. We are going today to discuss morphological assessment of the prostate, functional assessment, TNM and pyrite scoring, follow-up of treatment response. First, I should ask myself, should I ask for MRI or go ahead for the conventional truss biopsy and correlation with the PSA levels? We are going to discuss why we should perform MRI. MRI should be performed to assess proper staging in histopathologically proven prostatic carcinoma. Also, it helps to detect and localize cancer when PSA is persistently elevated while the routine truss biopsy is negative. MRI-guided biopsy is very crucial in assessing patients with elevated PSA, and truss biopsy is negative, but the PSA level remains highly suspicious. Also, MRI is very essential in assessing post-surgical, especially after radical prostatectomy when PSA levels remain elevated. How to perform MRI? MRI should be performed in a multiparametric fashion. We should perform it in a high field machine, either 1.5T or 3T. No endorectal coils is recommended, especially we perform it on a 3T machine. We perform two major imaging criteria. First, we perform morphological imaging, including T2 in multiplanar fashion. Also, we perform T1 weighted image to assess osseous load. Then we perform the functional imaging, including dynamic contrast enhanced study, diffusion and ADC, as well as MR spectroscopy. We assess MRI for the prostate in three major zones, including the central gland located here, then the peripheral gland, as well as the anterior fibromuscular stroma. In T2 weighted image, where we assess the morphological appearance of the prostate, we can see the central gland located here, and it has a heterogeneous appearance. The peripheral gland is a horseshoe appearance structure located at the periphery of the prostate, and it is fortunately of intensely high signal on T2 weighted image, and lucky for us because all prostatic tumors appear as a low signal on T2. The anterior fibromuscular stroma, which is a small structure located here as seen on the imaging. Cancer prostate is a multifocal disease, so if the truss biopsy revealed a single lesion, we can't exclude that this is the only residual or the only present tumor in this prostate. So we need further assessment to assess the multifocality. MRI show low T2 signal in all prostatic tumors. Also, anterior fibromuscular stromal lesions can be difficultly assessed either clinically or even on the truss biopsy. T2 for cancer prostate, as we mentioned earlier, in the peripheral zone is very easy to be depicted because the normal peripheral zone appear as a high signal and the tumor appear as a low signal. It can be diffuse as here, or it can be a focal disease as here. We can assess the prostatic extension very nicely in extraprostatic extension as we see here, and we are going to discuss shortly. Regarding the central gland, which is very difficult in assessment in truss biopsy as well as in MRI, we can see it as a focal masses as here, or it can be involving the anterior fibromuscular stroma. Then we come to functional imaging. After localizing where is the suspicious area, we perform more functional data, including diffusion, ADC, dynamic contrast enhanced study, and MRS. The diffusion weighted image is very crucial in functional assessment of the prostate because it nicely visualizes the tumor. Here in the T2 weighted image, we can see an altered signal here in the peripheral gland, and this is the ADC map originated from the diffusion showing very low signal. This low signal is very crucial in assessment of the aggressiveness. How we can perform this? These are two different patients. Here we can see abnormality here, and this is another patient with the abnormality seen at the left aspect. But notice here that the signal on this side is much darker than this lesion. Actually, this was furtherly proved by biopsy to have Gleason 5+4, but this have a Gleason score of 3+4. So the more darker signal, then the more aggressive the tumor is, and this was correlated with histopathological data. This was proved in the literature in a correlation of ADC values with the Gleason score, and it again proved that the lowest ADC value, which is a numerical data we can interpret from this map, is correlated with the higher Gleason score. Also, this is very crucial for the clinical assessment because we can assess the severity of the disease and its aggressiveness. With lower ADC value is the much aggressive tumor. Dynamic contrast enhanced study is also another tool to assess the microvascularity of the lesions, and we can plot color maps from this lesion to assess the tumor permeability, and we can get a numerical data known as K-trans, which is a measurable value for the tissue permeability. MR spectroscopy is used to assess the metabolic data of the prostate tissue. In normal prostatic gland, we can see here that the normal metabolite, which is the citrate, is remarkably elevated, while abnormal metabolite, which is the choline, is much lower. However, in cancer prostate, the opposite occurs with the low citrate values and elevated choline peaks. In the TNM staging, we play a very crucial role to assess the extraprostatic extension, either involvement of the prostatic capsule or the involvement of the seminal vesicles, and we proved to have very high accuracy in both items. Also, assessment of lymph nodes, which can be difficult to be assessed clinically, is our role in MRI with very high sensitivity as well. Extracapsular extension, as we mentioned earlier, which is a major concern for surgery, especially if the patient is going for performing nerve-sparing surgery. We use MRI to assess this involvement. Either we can find a sizable mass located outside the prostate with involvement of the neurovascular bundle, or we can assess minute microscopic extension beyond the prostatic capsule, which can be difficult to be assessed clinically. Recently, we rely on the PIRADS scoring for assessment of the prostatic carcinoma. In Virgin 2015, published lately, we divide the prostate not only in the three major parts we mentioned earlier, but we divide the prostate actually into 39 zones, and this is the maps where we are assessing every single portion in our imaging, including morphological and functional assessment. So, aggressiveness of the prostatic tumor, which is an indication of the aggressiveness of the tumor, and it's very important in clinical management, detected by MRI regarding the tumor volume and the tumor architecture, and also the Gleason score, as we mentioned earlier, correlation with the ADC value. The PIRADS scoring is established to assess a common communication with the radiologist and the clinical setting and the clinicians. And so European Society of Urogenital Radiology established this scoring, where PIRADS 1 and 2 are more likely to be benign lesions, while PIRADS 4 or 5 are more likely to have malignant lesions. So how we can use PIRADS clinically? If we mentioned in our report that we have a PIRADS 4 or 5 lesion, then this is a clinically significant disease, and then biopsy is furtherly required for this patient to confirm diagnosis and establish what will be the first next step for his management. Then if we mentioned by RADS 1 or 2, then this patient is having clinically insignificant disease, and we can avoid unnecessary biopsy in these patients. What about PIRADS 3? PIRADS 3 patient, if there is low clinical suspicion, then we can repeat this MRI 6 to 9 months later. While if we have a high clinical suspicion, then biopsy should be performed, but not the routine TRUS biopsy. We should be targeted biopsy from the lesions which are suspicious on MRI. And it's better to be performed MRI guided biopsy. And this is a published paper establishing the role of MRI, as we mentioned earlier, with high sensitivity and specificity and negative predictive value regarding MRI in assessing prostatic tumors. How about treatment? After treatment, after radical prostatectomy, we have a concern about if there is a residual tumor or there is a recurrence or this is a scar. MRI can nicely assess these entities by assessing their morphological appearance on T2 weighted images and also on the functional data, as we can see here in this example. This patient has total radical prostatectomy showing heterogeneous signal at the operative bed. We can't know if this is a residual tumor, recurrence, or this is just a scar. But the very low signal here is more indicative that this is a scar, and also this lesion on the ADC map show high value. But here there is an intermediate signal lesion, and notice the difference in signal between these two lesions. This is actually recurrent tumor at the operative bed. After radiation therapy, it is very crucial to assess if the patient is responder or is non-responder. But the timing is very crucial to assess this entity, and it should be postponed at least 3 months after stoppage of radiation to allow the inflammatory process to subside. MR spectroscopy is very important in assessing post-radiated prostate to assess the metabolic activity of the prostate rather than relying on the morphological appearance of the prostate alone. If we have androgen deprivation therapy, then the morphological changes of the prostate are major, and relying only on the morphological data is very difficult in the assessment. This is a mass, and this is before therapy. But notice the prostate show completely heterogeneous signal, including even the area which has no mass on the previous therapy setting. But we can rely on the dynamic study to assess if there is a residual tumor or there is a complete response. As noticed here, this is hypervascularity located in another patient on the right aspect of the gland. And notice after the treatment, there is no vascularity, indicative that this is a complete responder patient. This is from our cases. This case was recently diagnosed as a cancer prostate with very elevated Gleason score coming 5+5. So he was referred to us for assessing the preoperative staging. Unfortunately, the Gleason score was performed on the peripheral gland, and it shows that there are 2 lesions in the prostatic apex on either sides, but no affection of the central gland. Unfortunately, this was a video. I don't know if it works. Yes, it works. We discovered that this is a lesion here. There is another one here. But notice the central gland, which is very difficult in assessing by the TRUS biopsy, it includes another lesions as well. And this was furtherly confirmed on the ADC map with these lesions that was proved by the biopsy, and these lesions which are missed by the biopsy in spite of their huge size. And they are furtherly confirmed to be malignant using the MR spectroscopy with the elevated choline peaks, as we notice here, and also the hyperperfusion on the color maps. And fortunately, the patient has no osseous lesions at that time. Another case with prostate cancer coming for preoperative staging. This was a huge mass, and unfortunately the patient has extraprostatic extension with involvement of the left neurovascular bundle. Not only that, but there is also involvement of the seminal vesicles bilaterally. And this is the hemorrhagic components seen after the biopsy performed by the patient, which makes somewhat difficult assessment of the central gland after TRUS biopsy. And this is, unfortunately, metastatic lesion noted at the posterior right-sided ribs, noticed here on our T1 weighted image and after contrast injection. Another case with patient with hormonal therapy. If we rely only on this morphological image, it is very difficult to interpret where is the mass from the post-therapy changes. And so come the role of the dynamic contrast enhanced study, where there is a small lesion located at the right peripheral gland, and it also shows elevated choline peak, denoting that this patient is still having a small residual tumor. Another case, it was a very interesting case showing partial prostatectomy for benign prostatic hyperplasia. And after he performed the histopathological analysis for this benign prostatic hyperplasia specimen, it was proved to have a cancer inside. But no further assessment and no further therapy was performed. And only they were sufficient with following the PSA. Recently, the PSA is elevated, and the patient undergone the routine guidelines with performing another TRAS biopsy, and it came to be negative. So he was referred to our department for assessment. We can notice here a very huge mass located anteriorly, which was away from the TRAS biopsy. And it's a very aggressive tumor, which with the very low value on the ADC, with very bright signal on the diffusion weighted image, denoting that this is a very aggressive tumor. Unfortunately, the patient has also an internal iliac lymph node and also a metastatic distant lymph node implicating the left inguinal region. Just for 2 seconds, please. Just 2 seconds to finish up. Okay. Sorry. This is a patient with post-radical prostatectomy showing recent elevation of the PSA. He undergone CT pelvic abdomen. We don't know why he performed this study. It was performed outside our center, and the CT came negative. In spite, we can see something here at the bladder neck. And he came for MRI for better assessment. We can see the same lesion was noticed and missed on the previous CT, and we can see it here, but we can't discriminate if this is an actual recurrent lesion or this is fibrotic changes. And the functional data proved that this was a true recurrence with the pronounced diffusion restriction noted here, and also the remarkable elevated choline peaks. So to sum up what we are mentioning, MRI is very important in depicting the load of the metastatic cancer for the patient by assessing its aggressiveness, allowing proper stratification of the patient into low risk, intermediate risk, or high risk group, especially if the patient will undergo active surveillance for indolent tumors. Also, it is very crucial in assessing patients after therapy. Thank you.
Thank you, Dr. Rasha, for your excellent presentation. We may have time for 1 or 2 questions. Are there any questions? Yes.
First of all, I would like to congratulate you on this excellent work. But I have one question. In the cases where the patients are referred for detecting operability or staging prior to radical prostatectomy, why do you have to go through the 3 tests? Can't you do only one to detect the anatomical relations instead of going through the 3 tests with more expenses and more time?
Okay, thank you. This is a very excellent question, actually. First, if we rely only on the morphological data which are given by the routine MRI, it is very difficult to exclude mimickers of prostatic cancer, especially in these old patients who there are very huge mimickers which simulate prostatic cancer on the morphological data. For example, prostatitis, either focal or diffuse prostatitis, which is a great mimicker with a mild elevation of the PSA. So we can't rely only on morphology to assess if there is a tumor or there is a mimicker for the prostatic cancer. And this is the role of the functional data, which would give me more confidence to call it is a tumor or it's not.
Sorry to interrupt. He's already diagnosed with the cancer. He's referred to you for staging.
Okay.
Not for the diagnosis, for staging.
You are totally right, but as we mentioned earlier, the prostatic tumors are multifocal. So if he was proved to be by the TRAS biopsy having a single lesion, I can assess other lesions if they are prostatic tumors as well, or they are just inflammatory states or mimickers of the prostatic cancer. So that staging is very crucial in proper staging to identify if either one loop or two loops or there is extraprostatic extension, and to rely more on the aggressiveness of the tumor, especially if the patient will undergo an indolent tumors which can live for a long time without any intervention and undergo active surveillance later on. So this is the functional data to make me more confident calling them tumors, not just mimickers of prostatic cancer.
Okay.
Thank you very much for your excellent presentation, but I want to ask one question. Do you find that the addition of TRUS to MRI had improved the detection rate of cancer prostate, especially in transitional zone tumors where the only guidance is biopsy and PSA rising?
Actually, we don't ignore the value of TRUS in assessing the prostate. So but we should rely first on MRI before performing TRUS biopsy to avoid the hemorrhagic components and the other morphological changes. This is number one. We don't exclude the TRUS biopsy in diagnosing the patient with cancer prostate. And if we add it targeted to the region which was suspicious on MRI, it have more confidence in assessing the tumor and assessing that this is an actual tumor, it's not just an inflammatory or something else.
How much is the difference of addition TRUS in relation to MRI? Does it differ so much?
Yes, MRI has a higher sensitivity and specificity, especially for the central gland, which is very difficult to be performed by TRUS biopsy. And also, sometimes there are very anteriorly located lesions which are missed by the TRUS biopsy, and they are very difficult to be picked up during the biopsy performance. Also, the very peripheral lesions which are very difficult to be done with the TRUS biopsy. This is our role in MRI to detect these lesions in particular.
Thank you.
Okay, I have a small comment. You said in patient with paralysis 3, they are either low risk or high risk. You said that? And in the low risk, I didn't complete. In the low risk, you said you wait for 9 months to repeat the test. Is it long? Do you think?
Yes. Sometimes MRI has some limitations, and it is very difficult to call this is an actual lesion or there is nothing. So hereditary is actually meaning that
suspicious.
MRI. This is a suspicious. And so the whole case could be assessed, especially if there is a MDT for assessing some cases. If there is a very high suspicious for prostate cancer in this patient with post family history, very high elevated PSA, uprising PSA, free PSA, PSA density, other issues, clinical issues to be warranted that this is could be a potential malignant patient, then we should rely on the further biopsy, but we can get the biopsy from the area which was suspicious on MRI, not the routine 12-4 or 6-4 biopsy.
Thank you.
And the second topic will be on the best treatment in early breast cancer. It will be tackled by Professor Mohammed Gamal from the surgical point of view and Professor Ahmed Salim from the radiotherapeutic point of view.
First of all, I would like to thank the organizing committee, Dr. Shem Ghazali, for inviting me in this beautiful conference. It's the first time for me to address this conference. I didn't think it was going to be that huge and that successful, but I wish this will be repeated in years to come. First of all, I would like to say I might disappoint you. We are not here to debate the subject with my dear colleague Ahmed Salim, because I have a different concept regarding this. First of all, I think this is a wrong title. The wrong question is being asked. We are not competing with each other. Radiotherapy is not competing with surgery. We complement each other. We try to serve the best interest of the patient. The patient who is going to be served better with radiotherapy, well and good. The patient who is a good candidate for radical prostatectomy, we must give him his chance. Also, there is no treatment which fits all. There's nothing called radiotherapy for everybody or surgery for everybody. the treatment should be individualized according to multiple parameters. The clinical stage, the health of the patient, the life expectancy, his expectations, his limitations. So this decision should not be taken by a single clinician, whether he is a radiation oncologist or a urologist or a medical oncologist. It must be in the realm of a multidisciplinary team. Also, the patient choice and the patient desires must be taken into consideration in order not to face a frustrated patient after undergoing a major surgery. What do we have to offer to patients? First of all, we have to remember that there are other alternatives to surgery or radiotherapy, especially in certain group of patients. We can offer them watchful waiting or active surveillance, radical prostatectomy and radiotherapy, and on the horizon now there are a few investigational treatments such as cryotherapy or high intensity focused ultrasound and focal therapies, which need to be further investigated and might prove themselves to be alternatives to our standard treatments. First of all, we must define our patients and stratify them into risk groups in order to have proper comparison and can reach proper conclusions to our treatment. We all know about the low risk patients, the intermediate and the high risk patients, the localized patients and patients with a locally advanced disease. PSA less than 10, Gleason less than 7, and clinical T1 or T2A patients are categorized as low risk. Intermediate risk patients are those with a PSA between 10 and 20 and a Gleason of 7 and a clinical T2B, meaning involvement of the two lobes, and a PSA of more than 20, Gleason more than 7, or T2C or higher. They comprise the high risk group. The locally advanced patients are with any PSA, with any Gleason score, but they have either a nodal involvement or they are locally advanced, either infiltration of the bladder neck or of the seminal vesicles. What is radical prostatectomy? Radical prostatectomy is the entire removal of the prostate gland between the bladder and the urethra, together with the seminal vesicles and the vasal ampulla. We cannot leave any part of the seminal vesicles behind us because this is a potential site for recurrence of the tumor. Also, we need to remove all the surrounding tissues to obtain negative margins, but we need to, in some cases, to preserve the neurovascular bundles in order to preserve continence and potency. Bilateral pelvic lymph node dissection might be performed in some cases depending on the risk group and the degree of PSA elevation and the Gleason score. And now there is the concept of an extended pelvic lymph node dissection, which is up till now not proven to improve survival in all patients, and the extent of also is not up till now totally agreed upon. We have in our literature what we call the trifecta. What do we aim at? If we aim at total oncological control with a continent patient, with a patient who can perform sexually, then we have the best result. I hope in all my patients to have this, but ليس كل ما يتمناه المرء يدركه. There are different techniques of radical prostatectomy. First of all, there is the traditional retropubic open radical prostatectomy and the laparoscopic radical prostatectomy, and recently the robotic assisted laparoscopic radical prostatectomy. Regardless of the great hype in the media about robotics, there is no significant difference up till now between the three different techniques. Laparoscopic and robotic may have a shorter hospital stay, a rapid recovery, but oncologically and functionally there are no statistical difference up till now. The only statistical difference comes from the volume of cases you perform. If you refer cases to a big volume center which performs more than 50 radical prostatectomies per year, and to a surgeon who also has a big volume of cases, who is experienced in this procedure, then the results and the outcomes are much more better. Who should be offered a radical prostatectomy? Patients with localized disease, patients with locally advanced disease but which are still resectable, and patients who have at least 10 years of life expectancy. And they must have acceptable comorbidities which must be assessed properly and thoroughly before exposing them to the surgery. This statement I brought up just to tease my colleague Dr. Ahmed, and this is from our Bible, Campbell's Urology, this year. It says that there is no better way to cure cancer that is confined to the prostate than total surgical removal. I hope at the end of the 2 lectures, everybody will share this opinion. Now, in the era of evidence-based medicine, I cannot just say this, I need to prove it. And the only study which is randomized, prospective, and controlled is the study here presenting, comparing radical prostatectomy to watchful waiting. And this study is really an old one. It showed benefit for overall survival, cancer-specific survival, and time to development of metastasis in all were in favor of radical prostatectomy. It reduces all-cause mortality. The relative risk of deaths were decreased at 18 years, and there was a major decrease in prostate cancer-specific mortality, especially in younger patients below 65 years. There also was a decreased risk of metastasis in older patients more than 65 years. However, these results were not repeated in the PIVOT, the very famous PIVOT trial, which also compared the patients with radical prostatectomy versus patients on watchful waiting. However, the study population was a little bit different than the first study. There was more of intermediate and high-risk patients, which reflected on the outcome of the study. Now, what we can offer to our patients? We must, as I said, categorize them into the 3 standard categories: the low risk, the high risk, and the intermediate risk. In low risk patients, all these patients must be, before deciding on a treatment plan, must be aware of the result of the 2 previous studies I have mentioned to you, which have showed that there is a reduced mortality risk in prostate cancer at 18 years, and that the PIVOT study did not replicate these studies. But the probability of clinical progression and side effects and potential benefits of survival was really clear in this stage of the patients, and that a lymph node dissection in these low-risk patients is not needed, as less than 5% of them will harbor any lymph node deposits. The intermediate risk is a little bit different, because though there was improvement in death from any cause, death from prostate cancer and distant metastasis, but the results were not as good. And when they are performed in a multimodality treatment, as surgery followed by radiation or hormonal therapy, these had a much better results and much better 10-year and 15-year prostate cancer specific mortality rates, which have dropped significantly. The risk of harboring lymph node deposits in this group of patients is high. It's between 3 to 20%. Therefore, I think these patients should have a lymphadenectomy performed. High-risk group really are very tricky, because they have a locally advanced disease. However, when it's resectable and you can do your operation properly without major risks, then you have a better chance of improving the survival of the patient, and you definitely need to perform lymph node dissection. What are the complications of radical prostatectomy? The overall rate of complications is around 10%. Mortality is now nearly nil, especially when the patient is properly evaluated. And the early complications that we face are hemorrhage, rectal injury, urethral and nerve injuries, which are very also small in percentages, urinary leak, thromboembolic phenomena and cardiovascular events, lymphocele, wound problems, and UTI. This is taken from the European guidelines, and we see that the incidence of complications is really not that high, and it's even the Clavian 4 and 5 complications are as low as 0.6 to 2% at the maximum. So it's a really rather safe operation. What are the rate complications of radical prostatectomy? First of all, and the most dreaded, is urinary incontinence and erectile dysfunction, urethral stricture, and hernias of the wound or the port sites. Urinary incontinence occurs in 5% in most of the series. However, we must tell our patients that upon removal of the catheter, most of them will be incontinent or have urge incontinence, and that the incontinence improves dramatically over the first few days and weeks and up to 1 year. We do not actively manage them except after 1 year. The incidence of incontinence increases with age. We advise patients to do pelvic exercises, put them on anticholinergics. We might use bulking agents or slings or a sphincter if the incontinence preserves. Erectile dysfunction ranges from 20% to 100%. Don't believe the guys that tell you that our patients are potent. Age of the patient is very important. His preoperative potency status is very important in defining the outcome. Whether you have done a nerve sparing or a non-nerve sparing procedure also is very important. There are ways to improve the outcome by early rehabilitation using the phosphodiesterase inhibitors in order to stimulate the cavernous tissue and prevent cavernous fibrosis and improve sexual function. Improvements can occur up to 1 to 2 years, and intracavernous injection and vacuum devices might be tried first, and if it fails, a penile implant will solve the problem. To answer the question at the beginning, we have to go to the only prospective randomized trial that we have up till now, which is the D'Amico trial. This trial has been published in 1998, and at that point, it's still the only study available comparing radical prostatectomy to external beam radiation and to brachytherapy. However, we are waiting anxiously now for the results of this study, which is done in the UK. This study was brilliantly designed, and it recruited a lot of patients, and it has about 500 to 600 patients in each arm. Patients are either divided into watchful waiting, radical prostatectomy, or radiotherapy. The results will be available this year, and I hope this will answer our question. Thank you very much.
Thank you, Professor Gamal. I think Dr. Ahmed Slim would approach to give his point of view.
Thank you, Mr. Chairman, for the introduction, and thank you, Dr. Ghazali and Ain Shams University for organizing this very important meeting. Can we start working the slides, please? First of all, I teach the course of prostate cancer to my students every year, and the first statement I start my course for the prostate cancer that no treatment can equal surgery for the prostate cancer. Nothing can destroy and remove the cancer except surgery. But not all cases of cancer can be removed by surgery. This is the important message, because yes, we know that surgery is the only way, but many cases we have to discuss with Dr. Rasha, Dr. Salam Azim, and our colleagues in the MDT to pick up the patient who can completely removed by the surgery and patient who will need other treatment. The radiotherapy for the localized prostate cancer, we choose the modality according to the one of these modalities, as Dr. Mohammed Gamal mentioned. Our goal is the high cure and fewer modality of treatment. No point to treat the patient with surgery followed by the radiotherapy. One modality is efficient, and lower toxicity is very important. This is a balance and trade-off between these three factors that we need to reach. We don't have only one patient that fits all, or we have the low risk, intermediate risk, high risk, the very localized, very advanced, locally advanced. The difference between the size of the prostate, the infiltration of the capsule, infiltration of the neurovascular bundle, and lymph nodes, many factors interfere with the decision of whether radiotherapy or surgery is the better. So how to improve, how to counsel our patients? If you ask me, what's the role of radiotherapy? How can you improve your result by radiotherapy to reach the goal of cure? The cure can be increased in radiotherapy by dose escalation, by addition of androgen deprivation treatment to the external beam radiation. And recently, there is a discussion about the role of chemotherapy in the setting of locally advanced prostate cancer in association with external beam radiation. For the dose escalation, we have the biochemical free survival improvement, and some literature mentioned that overall survival is improved as well. And this is the standard of care in the 2016. We try to apply dose escalation more than 75 grays in cases to ablate the cancer. Androgen deprivation treatment is associated with improved overall survival, and it's standard of care and treatment of intermediate and high risk cases. But the chemotherapy, there is trend of overall survival. It's a very good hope, but it's under clinical trial and not standard yet. For the dose escalation, many literature with very good design randomized comparative studies proved that dose range between 70 to 79 and 70 and 78, there is a significant difference in biochemical failure free population in comparison to the dose. Also, one of the first trials, Dutch trial, it's a randomized comparative study, proved that biochemical failure free survival is established by the rising the dose from less than 70 to more than 75. But this study is very important. It's recently published in the JAMA Oncology in October 2015 and presented in ASTRO 2015. It's the first to prove overall survival in retrospective fashion of 42,000 patients. It's very significant, the big number, and it showed they compared between the dose of 86.4 and the doses to the less than 75 and more than 75 grays. For the low risk, there is no difference to apply these higher doses, but for the intermediate risk, big number, there's increased overall survival for the intermediate and high risk significantly for the escalated dose. So the message for my patient that I need to apply, and my students and my MDT, that I can achieve what's mentioned in the literature, that very good results of radiotherapy only when I apply dose escalation more than 75 in the intermediate and high risk. This is not a very simple maneuver, because our first priority to keep the rectum and the GIT toxicity minimal, as we mentioned very first, that it's a balance and trade-off between the dose and the cure and the toxicity. So as you see here, the very close proximity of the rectum to the prostate, so you need to review these criteria. Not more than 10% of the volume of the rectum should receive 75 grays. We may apply 80 and 85 and 90. So this is very theoretical. We have to localize our treatment to the prostate without any injury to the rectum lately. But so if we cannot apply this dose escalation, we cannot counsel our patient. There are two methods to increase the dose escalation in the prostate, either by very high conformal external beam radiotherapy, the whole prostate from 76 to 78, and localized by simultaneous integrated boost to the focal area to up to the 80 and more. But this needs, as I mentioned, boost to the focal area, but it needs very accurate IMRT, very accurate daily setup, over 40 fractions every day in the same position, because 1 millimeter matter, and daily producer bladder and rectal filling protocol. The bladder and rectum should be in the same position every day, because they may lead to a forward and backward movement of the prostate. So 1 millimeter matters, and this will violate the dose escalation. This is the one method how to increase the dose escalation. The other method, and also we have to combine this with the daily online IGRT. It's a very important. This is not feasible. It's not ready in every center to apply online imaging every day. The second methodology to dose escalate, that you give the prostate the external beam radiation for 50 grays, and you boost by brachytherapy if this facility available. In a comparison in randomized trial of 87 patients, comparing IMRT 86 is a very quite high dose to the 50 grays IMRT plus brachytherapy of 3 fraction high dose raised 4 hours apart. The dose is more or less equal, more than 100 grays. For biochemical free survival, the combo is much significantly better, and for the disease-free survival, it's better. The hazard ratio is significantly good. The acute toxicity for the just few weeks after the radiotherapy is high for the combo, but for the delayed toxicity are equal. This is a very sophisticated technology that with IMRT and brachytherapy we can think with the patient only when if we have these modalities. Should we irradiate the nodes or not? This is not a very big issue to a discussion with the patient, but we are not sure, because among 10 retrospective studies and 5 randomized trials, just one only study that proved that there is a significant importance of the elective pelvic node irradiation, but on the expense of the toxicity on the right hand, so at the cost of the toxicity. So we have to think always of the toxicity of the patient, particularly who are young, will live very long. What about the radiotherapy plus androgen deprivation treatment? This is one of the major benefits and merits and demerits, disadvantage and advantage of radiotherapy. That because we need androgen deprivation treatment, as you mentioned, for the intermediate and high risk. It decreased the size with better oncological activity and decreased the fibrosis. And we classify the androgen deprivation treatment in neoadjuvant before and during the radiotherapy and adjuvant. But as adjuvant treatment androgen deprivation treatment is very essential for the radiotherapy, it's also one of the very disadvantages of the radiotherapy when discussed with our patient, because for 3 years androgen deprivation treatment is very highly toxic, and radiotherapy is dependent on the androgen deprivation treatment for the results. So when we can compare with the surgery, we have to mention this disadvantage. For the androgen deprivation treatment, we have many trials. All showed that there is improvement in survival, and we have no discussion, yes or no, yes, it's much better. And a neoadjuvant 3 or 6 months, we proved that for the high risk, 6 months is much better. These are the summary of some of the randomized trials for the androgen deprivation treatment. For summary, according to the European Association of Neurology 2016, neoadjuvant is important for 2 to 3 months for the intermediate risk. It's no androgen deprivation treatment for the low risk patients, and 3 to 6 months for the high risk. Concomitant during the course of radiation is the most important, crucial, because it's a very important synergistic effect of the radiation. Adjuvant for 6 months in the low risk and intermediate risk, and 2 to 3 years for the high risk is the standard of care. Can we apply any chemotherapy for the localized castrate dependent, no castration, and yet it's localized, non-metastatic. Yes, we have some data. This is Professor Motet. This is the chairman of the guidelines of the European Association of Urology, presented in the last European Multi-Urology Cancer meeting 2015. One of very important two studies, DigiTalk 12, comparing androgen deprivation treatment plus localized radiotherapy plus docetaxel 75 milligrams every 3 weeks for 4 cycles in comparison to the standard of care androgen deprivation treatment and localized radiotherapy. If you look at the patient criteria, you will mention that you will notice that they are very high locally advanced cases. Remember this rectangular red because they wanted to reach hazard ratio 0.46 and two-sided 80% power, but when they presented the authors, when they presented the study, they failed to show double-sided ratio, and they cannot reach this hazard ratio. And the comment of Professor Motet that hazard ratio is not reached, unilateral test is not enough, and analysis is too early. And there is another study, RTOG 0021. It's a randomized phase 3 study of 2 arms comparing standard versus standard plus docetaxel. There is a trend for significant improvement of overall survival for 5 years, but the comment that we need longer follow-up and not yet as a standard of care. So the advantage of localized prostate cancer that we can avoid surgery with some complication. As Dr. Mohammed Gamal mentioned, that there is no surgery without complication, but we have discussed that patient. There is, for the radiotherapy, no immediate urinary incontinence and stricture, and there is short-term preservation of erectile dysfunction. But on the other hand, the course takes about 8 to 9 weeks. Temporary bladder symptoms during the course of radiotherapy, but can be resolved very early. Probable late erectile dysfunction after 2 years. Salvage prostatectomy is completely, absolutely impossible after failure of radiotherapy, and very high technology required, as we mentioned. And ADT is essential with all toxicity that we know about the 3 years of ADT. So the quality of life should be discussed with the patient according to the comparison prostatectomy. If you need to follow this, there is immediate complication after prostatectomy that can be resolved, but not to the baseline. But radiotherapy is more or less in the baseline for the urinary incontinence. Urinary irritation is associated with radiotherapy. Bowel rectal score is one of the major complications during the first few weeks of the radiotherapy. And for the sexual dysfunction, both techniques are associated with either initial decrease of the sexual dysfunction or at the late courses, vitality because of the androgen deprivation treatment. And for summary conclusion, the debate is not a debate, but we have to choose the proper patients. I need to remember the cases of Dr. Rasha, the first 3 cases. We have 3 different cases we can discuss with our colleagues. We can opt many different choices, whether the neurovascular bundle is infiltrated or not. Can the patient go with the R0 or R1? Many questions. The radiotherapy, you have to remember that radiotherapy dose escalation is not an easy. We need the high technology, and radiotherapy and ADT is a little bit toxic, and chemotherapy is not yet for discussion. And thank you for your attention.
Thank you very much, Dr. Ahmed, for this nice comprehensive talk. And I think we can take questions both for Professor Al-Gamal and Professor Ahmed Salim. Yeah.
Ismi Abdulaziz Al-Gamal, I published practice therapy in cancer journals like 18 years ago. Actually, it's one of the highest citation index that brought my Google Scholar citation index up to 1400. السؤال الأولاني, what's the status of practice right now? I understand you mentioned as a result of the combo. This is
in Egypt,
yes.
we don't have this facility in our country.
نمرة اثنين, why adjuvant monotherapy for 3 years with all these skeletal-related events? Actually, now I'm talking about the higher incidence of iatrogenic bone lesions after monotreatment that exceeds 16 months. نمرة ثلاثة, actually, if you have tried that technique for separation between the prostrato-rectal wound by injection of slime, just to minimize the dose of radiation to the rectum, as you mentioned, to make it less than 10%. Shukran.
Thank you very much for your very important comments. Actually, I mentioned 2 to 3 years because this is the standard in the NCCN and the UAA, and this is associated with better survival. You can discuss with the patient if you need to remove 10% chance, we can. But I hate radiotherapy because of the ATT, but we can sometimes not have other choices because surgery is possible. So in discussion during the first meeting with the patient, he has to opt whether to take the ATT for 2 to 3 years with all the complications that we are all aware of, or to leave that chance of very heated overall survival benefit in all trials.
في سؤال عن الدكتور جمال, لو ممكن هو في البوبيليشن بتاعنا احنا يعني how many high volume surgeons centers in Egypt that operate for more than 50 radical prostatectomy, other than the school of medicine?
I think there are only يعني want to say names يعني؟
هي دي ستاندرد كير, كان ستاندرد كير ان هو كمان ده ريليتد.
لا احنا في القصر يعني عندنا بنعمل حوالي بين 70 و80 حاله السنتر الثاني is a private center where we perform over 50 cases.
Population that are I mean, in the US, the 5-year survival for a patient newly diagnosed with prostate cancer exceeds 85%. As compared to 34% of the patients newly diagnosed with prostate cancer in North Africa or in our region, would have made it for 5 years. So in your selected population, or I would say actually selected, it's an advantage for some. What's the population or percentage of low risk, intermediate risk versus high risk that you see in prostate cancer patients?
Actually, now with the use of PSA, we see a lot of low-risk cases. In the university, we see more of the high-risk and locally advanced cases. Intermediate risk, I would say, it represents only 10-15% of our practice. Most of our cases are of the low risk or the advanced cases.
We don't have a screening program nationwide, and actually, in my experience locally from here, actually more than 65% of the patients I have seen are local, or sorry, I would say locally advanced. So I'm surprised actually. This is a population from, for example, Center of Excellence like Fuad, or I'm talking about Center of Excellence like Hassan. I'm a little bit surprised between the variation or the fluctuation between some areas or some centers, or you see 65% or above high risk.
We have to stress 65% out of because we don't have screening problem. We do 65% out of many final thousands. We very small population, so the higher percentage because we don't have screening. So comparison is not essential, but
I heard actually tertiary centers like المعهد القومي كده والسابق أو زي معرفة أنا أتذكر النهارده في الكلية بتاع ناشونال كانسر انستيتيوت prostate cancer possibility liver and cancer. بس انا حابب اتكلم على ان هو ازاي في سنتر زي المصريه والشعب شبه كده نشوف more than 2/3 of the patients in advanced stage. I've seen so many patients PSA more than 1,000.
What's your comment about the debate between radiotherapy and surgery?
I have very good experience. Actually, this is the best treatment for looking at breast
We need
cancer.
to experience because we need to reach the participants of this. How would you?
That teamwork اللي هو بيتكلم عليه الدكتور محمد بيتكلم عليه. This is actually true. I mean, in the era of personalized treatments, personalized patient treatment, we should consider the different stages between the locally advanced bone metastasis versus the node, especially with new advances in treatment of bone metastasis, which is not available right now in Egypt. Microscopy is available, but the radiant chemistry is not available. So I actually would say that as well as we are doing for the breast, you should consider prostate cancer completely or group. كويس ان في ناس هنا عندهم هذه السكيلز اللي هي بتعمل كده. It's اكثر ثاني بروستات ثاني كانسر نزلت في العالم. وانا ما اعتقدش ان احنا في نورث افريكا والميدل ايست are different than the US يعني population. We should have several regular meetings focused on prostate cancer. Should we consider a combination between XRT and radiotherapy for locally advanced prostate cancer that would not be cured with radical prostatectomy only. Also, for patients with low risk, the incidence of 5 year and 10 year survival without any brachy or any radio or any surgery is impressive. But in my population, my center population,
we have a very important discussion on the we have to sit with each other.
When I'm screening program, the government should pay my
Yes, please.
I would like to ask a question to both Professor Muhammad and Professor Ahmed. Yes.
أنا سمعت لازم من الشمس بشرف طبعا وجودي بس I'm anxious about one point about the terms used. I'd like to ask Dr. Jamal about the term high risk he used now. What do you mean by high risk?
It's a definition provided by Professor Gamal and Professor Sweet. High risk is high risk. High risk is BSA more than, it's a criteria is mentioned. BSA more than 20, clinical stage less than T2, Gleason score is 8 or.
Okay, this is you are speaking about
these criteria, only 2.
Yes, my perception and for the audience that use now high risk as if the metastatic room and in our but
may I intercede? We have to differentiate between two things.
Yes,
Metastatic, non-metastatic, okay, locally advanced, not localized. Localized is 3 categories, low, intermediate, and high risk.
What is the difference? This is what I'd like to ensure this. If I am in Notaria or Cairo or wherever, I think this has nothing to do with whether I receive more metastatic.
It depends on the locality and the type of population you see. Okay, maybe in Notaria, Nasrain, Ain Shams, we see patients who are symptomatic. Most of the symptomatic patients are either locally advanced or advanced. The other patients who come through PSA testing and finding an elevated PSA, دول كاتيجوري تاني ما بنشوفهمش عادة في المستشفيات الجامعية. صح. اللي احنا بنشوفه الايرلي ده هو اللي most probably detected by an elevated PSA. That's why I think الكلام اللي الدكتور عبد العزيز انه في النظريه عنده الاغلبيه is metastatic او advanced ده للاسف البور
organ confined
advanced and metastatic.
It's very interesting.
أنا بس عايز كلمة very small comment from the surgeon and the radiotherapist. When do you refer your patient to the radiotherapist, and when the radiotherapist refer his patient with early prostate cancer? to the surgeon. In short.
يعني فعلا احنا عشان دايما الدكتور محمد يعني my message to Dr. Muhammad Gamal صراحة if we have a lesion treating the capsule with bilateral infiltration of both neurovascular bundle after we have discussed the multi-parametric MRI, we need to discuss the toxicity of the influence and during dysfunction. Otherwise, if the disease is localized in the process with safe surgery, we have to offer surgery as much as
Also, I just may add the age and the body habits.
And what?
The body habits.
Yes.
Because obese patients don't do well with
surgery.
Patients with comorbidities don't do well with the surgery.